All right, welcome everybody. We're going to go ahead and get started. Welcome to our Rush Generations lecture on digestive health. And thank you for finding your way here to this lecture, whether you've joined in over the phone or if you're over on YouTube. Just a reminder, if you have any questions throughout our lecture, you are welcome to put it in the chat box. So if you're on the computer, it'll be on the right side of your screen. If you've joined in on a tablet, it'll be right at the bottom of the screen. But if you have any questions throughout the program, please do add any questions or comments and we'll moderate that over at the end. And so we're going to go ahead and get started by introducing our speaker for today, who's Dr. Michael Brown. Dr. Michael D. Brown attended medical school at the University of Illinois, graduating in 1981. His internal medicine residency was completed at Michael Reese Hospital and Medical Center in Chicago in 1984. He completed his gastroenterology fellowship at Michael Reese and the University of Chicago in 1987. He is a professor of medicine and senior attending at Rush University Medical Center in Chicago and is the program director of the Gastroenterology and Hepatology Fellowship at Rush, a position he has held for 17 years. He is a fellow in the American College of Physicians, American College of Gastroenterology, and the American Gastroenterological Association. He completed his master's degree in academic medicine from the University of Southern California in 2010. Research and clinical interests include colonoscopy, quality measures and preparations, use of simulation and endoscopic training, gastrointestinal BRAVO radiotelemetry methodology, and diagnosis and treatment of functional bowel disorders. He runs a focused functional bowel disorders clinic at Rush. He is chairman of the Continuing Medical Education Committee at Rush Oak Park Hospital, and he serves on the COSEP and curriculum committees in the Rush Medical College and the Graduate Medical Education Committee at Rush University. His favorite vacation spot is Bryce Canyon in Utah, as he is an avid hiker and bicyclist. As might be expected for an endoscopist, he still loves to play computer and video games in his spare time and is developing drone photography skills. So we definitely have a multi-talented speaker with us today, and we're going to go ahead and hand it over to Dr. Brown for a digestive health lecture.
Great, thanks.
Hello, Dr. Brown.
Hello, hello.
My patient, Peter Carmichael. You're my doctor. One of my many.
Perfect. I've heard this before. All right, let's see here. You guys seeing that okay, I assume?
Yeah.
We got a great president. No. Finally.
Yeah, we're in good shape, I think. Let me just get my this other window out of the way here. Hold on a second. Okay.
Can I ask the host? I'm sorry.
Oh, there we go. Okay, just cleaning out the windows here. So yeah, so today I'll talk about constipation, acid reflux. And the reason I cover those two topics, those are the most common complaints in my clinic. And matter of fact, for a lot of GI clinics, those are the most two common issues we see is persistent or severe constipation and particularly problematic acid reflux. I'll spend a fair amount of time, because this comes up almost every visit with patients who have acid reflux, on the long-term use of heartburn medications. There's a lot of noise in the media out there, and you know, Dr. Google has his or her opinions on this, so I'll give you mine. But yeah, it's important because, well, as we'll discuss, acid reflux is a long-term disease that needs long-term treatment to keep you healthy, and therefore we end up using these medications fairly frequently and for long-term periods of time. Yeah, Rush has changed a little bit over the last couple hundred years, 800 years or so there, from our one single little brick building to this thing. So yeah, a lot of changes. So on to constipation. So what is constipation? It's got a lot of definitions, and a lot of them are patient-driven. I'll give you the medical definition, but I think the medical definition misses a lot of people. So is it hard or difficult to pass stools, a sense of incomplete evacuation, infrequent bowel movements, abdominal pain and bloating between bowel movements, frequent loose, small volume bowel movements, a common problem. And it's actually all of the above. Like I said, it is probably makes up about 80 to 82% of my office visits on a day-to-day basis to have some component of constipation. The patients may not present with constipation as the main issue, but they have abdominal discomfort, abdominal pain, abdominal bloating. Sometimes they even come in with diarrhea, and a lot of chronic diarrhea is something we'll talk about. It's actually called post-obstructive or paradoxic diarrhea because it's due to constipation and the inability of the colon to store any more fecal material. So you have these frequent loose bowel movements that patients will interpret, and sometimes the doctors interpret as diarrhea. And then when you treat the patient for diarrhea who's baseline constipated, you make things a lot worse. So important to recognize that. As I mentioned, the most common complaint I see in clinic without question. So a little bit on how we diagnose it and how we treat it. Some of the more modern treatments for constipation I'll cover in some depth. This is called the Rome 4 criteria. It's kind of nice. It's the criteria we use to diagnose at a medical level constipation. So if patients meet these criteria, they have constipation, chronic constipation. They don't need a lot of diagnostic testing to prove that issue. So anybody who has recurrent abdominal pain, on average about once a day per week or so for the last 3 months, associated with that pain being related to defecation, associated with the change in the stool frequency, in this case constipation, or associated with the change in the form or the appearance of the stool such that it becomes hard or pellet-like. Those would be criteria that we would consider positive for either chronic constipation or constipation predominant irritable bowel syndrome. Those are two different disorders. Chronic constipation, where it is a situation where there's only a change in the stool frequency or form and no pain. When pain, and we actually use the word pain is involved, then it becomes irritable bowel syndrome. And since the treatments are different for the two, we like to nuance that out a bit. So pain is the key operative word there. Pain means irritable bowel syndrome with constipation. When it's just the change in stool frequency and form, we're looking at chronic idiopathic or chronic constipation. And irritable bowel syndrome becomes an incorrect diagnosis in that setting. Oftentimes, patients will get irritable bowel syndrome is kind of what we call a wastebasket term. Everybody gets labeled as irritable bowel syndrome without really following the guidelines as to how you diagnose that. And that's a problem because not everybody has irritable bowel syndrome. The treatments for irritable bowel syndrome will not work in patients who don't have it. So it pays to be precise and not use that term for anybody with a chronic complaint in the GI tract that defies, a clear anatomic diagnosis. In other words, with a lot of negative testing. So this is the Bristol Stool Form Scale. It was invented in Bristol, England. It's quite accurate in predicting patients who have constipation and diarrhea, and it's very good at predicting the transit rates in the bowel. So we use this a lot. I have these cards in clinic. And so you can see it goes away from type 7, where basically patients have very short transit times in the colon, less than 10 hours with a lot of watery stool, all the way up to very hard or lump-like stools that indicate transit rates that can exceed 100 hours. I've had patients with transit rates that exceed 150 hours. So in that time, the stool goes from entirely liquid to dried out and desiccated because the colon is basically a big sponge. It's a water reclamation device. Doesn't absorb a lot of nutrients, isn't really involved in your nutritional status. You could certainly lose your colon and not become malnourished. But it is important in taking the liter of stool you give it per day and distilling that down to a bowel movement like type 4 here, about 100 milliliters of stool a day. So it removes 90% of the water that it gets every day from the small intestine. If it stays in there too long, it's going to remove a lot more than that. And you're going to get this dry, desiccated stool because it stays in the colon too long. The colon continues to extract water and you get hard, difficult to pass stools. So a lot of you'll see the treatments we're going to show down the road are aimed at delivering a larger water content into the stool and keeping it in the stool so that the colon cannot extract all of it. That water in the colon stimulates the colon to move in a natural fashion. So the colon likes water, responds to it, increases motility innately, and that's a good way of improving bowel movements. So these are red flags. So red flags are things that mean that maybe this just isn't your run-of-the-mill constipation, and maybe there's something else going on. So If in laboratory testing you're anemic, or you're having fevers, or you have diarrhea all the time, it's unrelenting. You can't even get through a day, entire day without having liquid bowel movements, and you're getting up in the middle of the night to go to the bathroom. That's not irritable bowel syndrome or chronic constipation, obviously. Any kind of rectal bleeding. If constipation is to the point that you're going a week without a bowel movement, that's a little different than irritable bowel syndrome with constipation, or functional or chronic idiopathic constipation. Weight loss does not occur with these functional or brain-gut interaction disorders like chronic constipation. We don't like to see nocturnal symptoms of pain or abnormal bowel function. Usually most people with irritable bowel syndrome or with chronic constipation can make it through the night pretty nicely. We don't want to see a family history of other GI disorders that we need to sort out. And typically, if your symptoms started above age 50, we're going to take them a little more aggressively diagnostically than if you come in to see me at age 25 and have had 5 years of constipation. So those are the red flags. Those are the things that usually drive us to more aggressive diagnostic testing to make sure there's not something else going on. That said, people with red flags can come back and still have irritable bowel syndrome and still have chronic constipation. But to get to that diagnosis, we're probably going to have to do some more aggressive diagnostic testing than, let's say, if you come in at 25 years old, you've had chronic constipation for 5 years, we might not have to do a lot of x-rays or endoscopies or other laboratory testing to sort you out. We might be able to go right to treatment and see how things go first. This is key when dealing with what I deal with a lot of what are called, well, we're changing the name. It used to be called functional GI disorders. Those were problems in GI function and motility and symptoms that were related to more neurologic abnormalities in the gut, maybe the way it moves and the way it responds to stimulus, not so much something structural like inflammation or a tumor or an obstruction or a stricture. So a lot of the tests we do are really good at finding anatomic abnormalities like ulcers and inflammation and cancers and tumors. They're not very good. Matter of fact, they're terrible at assessing the motility of your colon, how much your colon secretes, how slow is it, how fast is it, how much water does it take out. I can't see those things with a scope. I cannot see them with a CT scan. I can't see them on x-ray. They aren't very easily detected in blood tests. So when all of that stuff is done, and if it all looks pretty good and we don't see anything abnormal, then patients fall into my realm of expertise, which is what were called functional bowel disorders. And now in the last year, we've changed the name to be a little more accurate. We call them disorders of brain-gut interaction. So your brain and your gut talk a lot. There are more connections between your brain and your gut than any other sets of organs in your body. That continuous conversation is driven by what the bowel is sensing is going on in there. It senses its distension, it senses the chemical content, it senses a lot of things. And that information goes to the brain, which then acts on it. When there is a miscommunication between the brain and the gut, then things that are not favorable happen. Altered bowel motility can occur, altered secretion can occur, altered absorption can occur, and all of these things can lead to symptoms. The frustration for patients who have these kind of brain-gut disorders is that you can't see them. I cannot show you an x-ray picture of it. I cannot show you a biopsy. I cannot show you an endoscopic appearance. So it's frustrating. And if the physicians don't spend time explaining why you can have all these symptoms of constipation or diarrhea or abdominal pain, of bloating, et cetera, of even heartburn, with negative tests, then this just becomes frustrating. There's no validation of your symptoms. You probably get treatments you don't really need that aren't particularly helpful. Patients get told to do the same thing over and over again and get frustrated by it. What happens though is as your confidence in the diagnosis goes up and the patient's confidence in the diagnosis goes up, symptoms tend to get better. So knowing what's going on, having a baseline understanding of why you can have all these symptoms with negative tests, understanding it at a very lay level or basic level how the brain and the gut interact with each other and how things get kind of messed up when they don't talk correctly is very helpful in getting patients better and reducing the symptoms. There's probably nothing more frustrating than having lots of symptoms and everybody telling you, there's nothing here, I can't help you. Keep moving along. So some of the tests we do in the early going is we try to look for evidence of fecal impaction. This is probably the most common test I do in my clinic. It's just a plain x-ray of the abdomen. If there's a lot of retained fecal material in this left side of the colon, then that's helpful to me to know that even though the patient's having 7 bowel movements a day, this is not an issue of diarrhea. This is an issue of obstructed defecation. What happens in that setting is the whole left colon, which is basically a storage area where you keep stool until it's socially acceptable to have a bowel movement, is all filled with stool already. So the liquidy stool over here in the right side of the colon comes scooting around over here, and there's no room in the end, right? There's no space for it. So it leaks as a liquid stool out of you, and you have these multiple frequent, what we call hyperdefecation events. From a patient standpoint, that's diarrhea, right? You're having 7 bowel movements a day. From a physician's sense, this is paradoxic diarrhea, post-obstructive diarrhea. And weirdly enough, you treat that kind of diarrhea with anti-constipating medications. Many patients with an image like this are going to have a lot of bloating, abdominal discomfort, maybe some cramping down here in the left lower quadrant. It's going to be uncomfortable. The bowel movements, instead of all of the left colon being cleared out during a bowel movement, maybe 80% coming out, maybe only 10 or 20% comes out. So you get up from the toilet, you feel like you had a decent bowel movement, but 20 minutes later, you're like, oh my goodness, I gotta go back again. So I have a lot of patients who have this sense of incomplete evacuation because only a small percentage of this entire fecal mass is coming out. And that's a version of constipation. So we can see that with what's called a KUB or flat plate. This is a flat plate x-ray to the abdomen. And you can see down here, there's this kind of grayish area that looks kind of inhomogeneous. This is a fecal impaction, and this whole left colon, it's all kind of gray and kind of a white and gray area here. This is all fecal material that's impacted. And you can see the sort of the dark area behind it is all the bowel that's distended, because none of that gas and stool can get beyond this fecal impaction. So this person needs to get on anti-constipating medications. Maybe we need to clear it out with a bowel prep just to get all this out of here, restore everything to a nice clean baseline and make them better. Usually we start with this test. It's simple, it's safe, it's a low radiation dose. It takes all of 10 minutes and gives us a nice clue as to the status of the colon between bowel habits. Sometimes we move on to other testing like anal rectal manometry. This is a very simple test. We don't do it all that often, but once in a while when someone really isn't responding to medical therapy, we might have to measure how the sphincter valve down here is working. Is it not opening correctly to let stool out? Is it getting stuck? Is it too tight? In the case of incontinence, could it be too loose? We have a little balloon we put up in here, and we expand the balloon and ask you when you feel like you have to have a bowel movement. Is the rectum too insensitive? Is it not picking up stool when it should notice it's there and request a bowel movement? We then ask you to expel the balloon. If you cannot expel the balloon in 1 minute, that indicates there's something wrong with the muscles in the pelvic floor, maybe this anal sphincter, maybe things aren't opening up quite the way they should. One of the tests we do to look at how the muscles down here are working or not working is we use magnetic resonance stethoscopy, fancy term for a kind of a fancy imaging study where they'll put a little Vaseline in there that's got a radial label and they'll ask you to expel it. And we can watch these muscles moving down here. This should be like a big piston. This whole pelvic floor should drop and push things down. There's a drawbridge-like muscle called the pubic muscle that should open. This anal sphincter down here should open. So there's a whole choreography. There's a whole dance down here that has to occur for you to have a bowel movement. And if all 3 of those things aren't working together, then you're going to have trouble. And if, for instance, let's say the pelvic floor piston's working great and the pubic drawbridge opens up nicely, but our anal sphincter down here isn't playing along and doesn't open, you can't have a decent bowel movement and you're going to get frustrated. And so obstructive defecation is one of the reasons when we see patients in clinic who've not responded to typically effective medical therapy, we need to get into this muscle work down here and see if there's something we can fix. I see a lot of patients who get colonoscopy for constipation complaints. It is probably the most worthless test we do. Constipation is almost never caused by something structurally we can see with a colonoscope. A colonoscope cannot measure motility. A colonoscope cannot assess pelvic function. A colonoscope cannot assess anal rectal manometry. A colonoscope can't assess fecal retention between bowel movements. So yeah, it can rule out the 1 in 10,000 cases where colon cancer might be causing constipation. But in 32 years of practice, I've never seen that personally. I've never seen anybody come in with chronic constipation who had a colon cancer that was causing it. I've done colonoscopies on people who are constipated and found colon polyps and cancers, but it had nothing to do with their constipation. So although that is the first test a lot of gastroenterologists will do for constipation, it is probably the most worthless as far as giving you an answer to your problems. And I know patients I see get frustrated because when you come in for constipation, they just keep doing this test over and over. They don't get into the more nuanced testing that really makes a difference for people. So if you've had your one colonoscopy and it looks okay, and you don't need any more for 10 years or 5 years if you have polyps, then you certainly don't need these repeated because of issues with constipation. Just not going to be helpful. So the current management components of constipation are education, sort of give you guys an idea as to why you're constipated, what are the issues with motility and secretion that cause this problem. Reassurance that yes, you don't have a colon cancer causing this. Yes, this is a chronic problem, but not one that indicates or requires surgery or anything terribly aggressive interventionally. There are dietary modifications. We'll talk about fiber a little bit, about how helpful or unhelpful it can be. There are symptomatic treatments that are quite effective. We'll go over those. There are even psychological and behavioral options that can be helpful in controlling particularly some of the pain related to constipation. And then we need to set realistic goals. I've not cured anybody of constipation. I've made them a lot better and resolved their symptoms, but a cure is pretty tough. As the colon ages, it elongates, its motility declines a bit. You develop problems like diverticulosis that can impede the transit of stool through the colon. And I can't reverse aging yet. One day maybe, but not right now. So unfortunately, an aging colon is one that tends to be susceptible to constipation, and we have to work with that aging colon and help it along a little bit. So what about diet? Everybody kind of, anytime the GI tract's involved in anything, we always focus on diet. Diet's probably a little oversold as being effective in constipation. Certainly a little fiber helps a little bit. If your constipation's mild, increasing your fiber intake will drive more water into the colon and will help it move a bit. There's one big downside to fiber though, and that fiber is a carbohydrate that you can't absorb, which is fine. It goes down your colon and helps give volume to stool. As a matter of fact, most of what you pass in the way of fecal material is unabsorbed carbohydrates because fats and proteins are highly absorbed. The problem with, this is not a real problem, but the issue with fiber is that fiber, when it gets to your colon, is fermented. So remember, fermentation is the process by which bacteria break down sugars and create gas, right? So that's what they do in your colon. So the vast majority of the 2 liters of gas you produce per day come from the fermentation of carbohydrates in your colon. So if you give your bacteria in your colon more to eat and more to do, they will merrily ferment along and they will make more gas. So as you might guess, people who eat a lot of bran or artificial fibers or sugar substitutes or vegetables and fruits, which are fine, will make more gas. And there's nothing really wrong with that. It just shows that you're feeding your bacteria in your colon and they're happy with you and they're metabolizing away, which is good for your colon. But it's making a lot of gas. And so people who are vegetarians just pass more flatus than those who aren't. If you start eating a whole lot of fiber and you haven't eaten a lot of fiber in your life, you're going to make a heck of a lot more gas. You're going to have more flatus. You're going to have a little more bloating. That might be uncomfortable. So you have to be wary of that. And so some patients, in trying to treat their constipation with tons of fiber, will get into trouble with a lot of fecal material in the colon because it's a bulking agent and a lot of gas. So if fiber ain't doing it, then you need to back down on that a little bit. As a matter of fact, by the time people come to see me, they've almost always tried fiber. They've either had no good effect with it or are getting a lot of gas or discomfort or bloating or distension, and it's time to move on a little bit from fiber. So again, no harm in that. It's just you might get uncomfortable with it. By the way, from the standpoint of gas, the other place you get gas in the GI tract is from swallowing it. So every time you eat, you swallow some air. That has to come out one of 2 ways. You're going to either belch it out from the esophagus or stomach, or you're going to pass it down below as flatus. And that's it. So when you have gas in the GI tract, it's either fermentation of carbohydrates or it's air you swallowed while eating. So Mark Twain once said, eat what you want, let the food fight it out inside. I sort of take that approach to diets with my patients. They're so much better at telling you what they can tolerate and can't. I mean, one man or woman's poison's another's dessert. And it's hard sometimes to come up with rigid dietary constraints. I see patients put themselves on amazingly draconian, very difficult and very restrictive diets without a lot of data that helps a great deal. So you'll know what works for you. If you can handle high fiber, then and it helps your constipation, I'm all for it. If on the other hand, even modest amounts of fiber cause a lot of bloating and gas and pain without much effect on the constipation, I'm not going to push fiber at you. Definitely not. This is what has been termed by nurses the preached trio, what every patient with constipation is told to do over and over again. One is, we talked about, eat more fiber. The other is get more exercise, and the other is drink more water. To date, there's no data that any of these are particularly helpful in more advanced forms of constipation. Eating more fiber helps a little bit, but again, at the price of a little extra gas, and some people don't get better. There is not a great deal of data that exercising makes your colon move. Yeah, you're moving, it doesn't necessarily mean your colon's moving. Matter of fact, there's data showing that when people exercise aggressively, the blood flow goes away from your bowel and it goes to other areas like your muscles and your heart and your lungs and your brain. Your gut gets taken away from it. And if a gut that isn't getting a lot of blood doesn't see a great deal to need to move. So actually, people exercise a great deal actually don't get a tremendous amount of increase in motility. So I can't say that there's any hard, solid data that getting more exercise will increase your bowel movements. That said, if you're running a marathon and you get to the point where you're running so much that the blood loss to the colon causes it to start to leak or get irritated, then you can actually see bleeding and diarrhea with really aggressive exercising. But that's kind of like marathon runners. That's people who are doing triathlons and such. That's not, if you get on the exercycle for 30 minutes or you work with a stair climber for 20 minutes, you're not going to get to the point that you get such low blood flow to your gut that it damages it. But that's the only reason you're going to see an increase in bowel movements if you're exercising to the point of extreme like that. And drinking more water. Yeah, water is great if you take it with fiber or some of the medications like Miralax that we use for constipation. But just drinking water alone is not going to make more poop. It's going to make more urine. So you'll go to the bathroom a lot, but you'll go to urinate, not to defecate. Your small bowel has the surface area of 2 tennis courts laid end to end. It is a huge surface area for absorption, and it will merrily absorb every drop of water you give it. And if it's too much for your body, you'll urinate it out. It's not going to make it to your colon. The only way to get it to your colon is to pull it there with something that acts like a water magnet, if you will, and that would be like the fiber, which can do that, and then osmotic laxatives, and we'll talk about those in a minute. But that's things you're probably familiar with, like magnesium citrate, magnesium sulfate, milk of magnesia, lactulose, Miralax or paraffin glycol are all osmotic laxatives, and they work by taking that water you drink and pulling it into the colon, not letting the small bowel eliminate it in the form of urine. So water only works if it's got somebody to pull it down to the colon along for the ride, and that's osmotic laxatives. So what does work? And it's not a one-size-fits-all approach. Everybody I see is individualized, and we have to work through. We try different things. We try different doses. We try combinations of things, and we ultimately find something that works. But it's definitely not a one-size-fits-all approach. So let me talk about antispasmodics and anticholinergics. I don't use these often. The main reason that in constipation, at least, they worsen it. So they're all constipating. So if you're trying to treat pain, and in a patient with constipation, and you're giving them a drug that worsens constipation, I think you're working at cross purposes. This is not going to work out well. I see a lot of patients on these. I use them intermittently. I think they're great for crampy abdominal pain. They're okay if used intermittently. They're not great due to these side effects of dry mouth, dry eyes, and again, worsening constipation. So if I'm really up against the wall and pain is the main issue and we're doing pretty well with the constipation, I'll try them out, but I'm not a huge fan, and particularly in patients with constipation. In patients with pain and diarrhea, maybe a little more applicable, but not great drugs for constipated patients. So on to laxatives and bulking agents. So these are good for symptomatically controlling constipation. As I mentioned, you can increase your daily fiber intake. That could be Metamucil. It could be you just eat more fruits and vegetables. If you want the fruits that have the highest content of fiber per weight, it would be berries. So strawberries, blueberries, blackberries, raspberries, gooseberries, whatever kind of berry you want. Ounce for ounce, pound for pound, berries contain more fiber than other things like apples and pears and such. So if you want to do it naturally, you want to just take something that you buy at the grocery store, then berries are the way to go. If you want to do it like in the form of a tablespoon of something here or there, Metamucil's fine, that's psyllium, Benefiber, any over-the-counter fiber supplement's fine. Again, they work only in mild cases, and don't overdo it. A tablespoon, maybe a max of a tablespoon in a glass of water a day of a fiber substitute. After that, you're just going to get a lot of bulking and bloating. You're not going to be too happy. I prefer osmotic laxatives. That would be magnesium sulfate, milk of magnesium, lactulose. Not a huge fan of lactulose. Patients get a lot of gas with it, so I don't use it too much. I use a lot of PEG, which is paraffin glycol. All of these are safe. All of these can be used long-term. None of these habituate the colon or cause it to lose response over time. You can take a fair amount of these every day without any trouble. You know, actually we use huge amounts of Miralax actually in the form of PEG in bowel preparations to clean people out for colonoscopy. So these are all quite safe. Most patients I see with Miralax are using a capful or 17 grams once or twice a day. It will pull water into the colon, do a nice job of softening the stool, giving you a more complete evacuation, and giving you more frequent bowel movements. And it doesn't really cause too much diarrhea. They are not very good for pain. In fact, they don't have any indication in irritable bowel syndrome because they don't help with the neuropathic pain that's associated with that syndrome, but they're very helpful in chronic constipation. Stimulant laxatives, not a huge fan of these. I think they're okay intermittently. This is Dulcolax, Senna, Cascara. Senna and Cascara show up in a lot of herbal teas and a lot of over-the-counter laxatives like Smooth Move and such. Why don't I like them? They're irritants. So the way they work is that they go down to the nerve endings in your colon and they make the colon move whether it wants to or not. So they irritate or stimulate the nerve endings to contract. That can certainly empty your colon, and they do work. There's no doubt they'll help, stimulate a bowel movement. Downsides, they can cause cramping because they're making your colon contract whether there's stool in there or not. And over time, if you keep taking these day in, day out, they will habituate your colon. So after a while, your colon, if it's not getting stimulation through these drugs, it won't work anymore. So when you stop them, your colon will stop working. The other problem is that if you keep taking these long term, you'll find that you need higher and higher doses. Some of you may have or have seen something called melanosis coli. This is a black stain in the wall of the colon related to the deposition of breakdown products from these drugs. If you stop them, that'll go away in about a year. It's benign. It's just a byproduct of their metabolism in the wall of the colon. So if you've been told you have melanosis coli, it probably means that you're taking these, and you may not know you're taking them. They can be an herbal tea, and you don't even know there's some Senna or Cascara in there. So if somebody ever told you had this darkening of the colon wall and you're not sure where it's coming from, take a look at any herbal remedies or teas you're consuming. Again, it's no hazard to have this black dark lining to the colon, but it does mean you're probably overdoing a bit with these drugs, and over time that can be a bit of a problem. So not my favorites. I think they're okay for intermittent use. I'm not a big fan of them long term. Here's melanosis coli. It looks like a coal mine when you get in there. It's sort of this black darkening. This is all the breakdown product of those drugs, that Senna, Cascara, and Dulcolax in the wall of the colon. And it looks scary, but it doesn't cause any trouble. Matter of fact, one of the interesting effects of this, it makes it easy to find polyps because the polyps won't pick up this dark stain. So when we're coming out, it's very easy to find polyps in folks who have melanosis. We do tend to see it in refractory constipation because patients are taking lots of Senna or Cascara to try to get their colon moving, and it's unsuccessful. So they build up this breakdown product in the colon wall. So some mythologies, the patients are always told they need to drink more fluids, they need to get more exercise, they need to eat, that should be more fiber. They're told that all their drugs cause constipation, that they have undiagnosed things like hypothyroidism, that they have some obstructing colon or rectal cancer mass, and for the most part, all of these are not true. Don't get me wrong, there are drugs that cause constipation, and we'll talk about that. Not all of them do. And opiates in particular are rough. But otherwise, most of this is not true in the patients I see in clinic. They've tried all these things, they're not working. You need to move on from those mythologies. So I want to cover some of the newer FDA-approved medications. You may have seen ads for these on TV because obviously constipation is common, so you're going to see a lot of advertisements for common things. Lubiprostone, Amitiza. This opens up gut water channels and allows increased small bowel water to get to your colon. As a result of that, the colon picks up the pace and gets moving. It does reduce, here's key point, it reduces abdominal pain. That's the reason the FDA approved this drug, Amitiza or Lubiprostone, for constipation, predominant irritable bowel syndrome, and routine non-painful constipation, because it does fix pain if you got it, and it will help with bloating. We use it as a 24 microgram twice a day drug in constipation. It can be used at a lower dose in irritable bowel syndrome. There is a limiting side effect of some nausea, rare vomiting in about 15%, although that number drops quite significantly if you take the medicine with meals. So this is twice a day with meals. And it can be used with things like Miralax or fiber, etc. So you can add on if you need it. That's one option. Here's another new one you may see advertisements for called LINZESS or LINACLOTIDE. This one actually is interesting. It mimics the bacterial toxin that causes traveler's diarrhea. So what it does is it increases the small bowel water flow, and again, colonic motility, just like you'd like it to. It reduces pain and bloating, so it's good in irritable bowel syndrome. There's a nice dose range that allows us to titrate this drug to the dose the patient needs to avoid diarrhea, yet have a good bowel movement. 60-70% response rates are pretty good. Remember, this is in people who failed other things like Miralax or Senna or fiber. Only side effect is diarrhea. By the way, any drug any doctor gives you to treat constipation, it's going to have a side effect of diarrhea. Any drug we give you for diarrhea is going to have a side effect of constipation. It's just too much of a good thing. So what we have to do, like say with LINZESS, let's say you're taking 290 micrograms a day, you start getting too many bowel movements, we're going to back it down to 145 or maybe 72 a day. So I like LINZESS because it's safe. It is not absorbed in your bloodstream. It does not interact with any other drugs. It is safe for long-term use, with the main side effect being too many bowel movements, and then you can cut the dose back. And a good response rate, 70%. So we use a fair amount of this. Lately, I've noticed insurance companies are covering this drug. It's like a tier 1, tier 2 drug from a cost standpoint. It's not too bad. TRULANCE or PLENACLATIDE mimics, again, the human neurotransmitter that increases water secretion. It's very similar to LINZESS. It's more sort of modeled after the human neurotransmitter. It has only one dose, though, 3 milligrams a day. So it's a one-size-fits-all approach. Again, for long-term control of chronic constipation, only side effect is diarrhea, no nausea, no vomiting, doesn't interact with any other drugs, safe in long-term use. Key point about all the medicines I'm mentioning now, none of these habituate. In other words, if you stop them, your colon will go back to behaving the way it did before you took them, but you won't be any worse for wear. You do not become dependent on these drugs. So if you don't like the effect you're getting with it, or you just want to stop because you're feeling better, when you stop it, it won't be terrible for you. You'll just go back to whatever you were before you took the drug. So safe in that regard. Here's one of the newer kids on the block, PRUCALOPRIDE. MOTEGRITY came out last year. This works a little different than the others. It's another neurotransmitter type drug again. Now this one improves all bowel motility, not just your colon, your small bowel, but also the stomach motility gets in the act on this one. So everybody gets moving a little better. It is again for chronic constipation and irritable bowel syndrome. It's a one size dose, 2 milligrams a day, and 1 milligram if you have some kidney trouble. Main side effect, diarrhea, nausea. In children, there was some issue of suicidal ideation, so it is not to be used in children under the age, I believe it is 13 years old. So I don't take care of kids, so not much of an issue for me. But that's the one side effect, and they've only noticed it in children. So one other option you have in treating pain in these kind of brain gut disorders is called neuromodulation. And that is where we use antidepressant drugs, not for depression, but because they alter the nerve signaling in the gut that help reduce pain. And this can lead to, even really nifty, can lead to long-lasting repair of the nerves in the gut and reduce pain, which is nice. They're great for pain. They can worsen constipation, so they're not my favorite medicine in constipated patients unless I'm really having trouble controlling their pain. And there they work really nicely. They take a little while to kick in, usually a few weeks, not a few days. But we've had a lot of success with neuromodulation. These are some of the drugs you might recognize as antidepressants. I usually have to tell my patients not to panic and run home and get on Google and search and see I'm trying to treat them for depression. I'm not. We use these drugs in very low doses, not the doses used to treat depression. They won't make you happy when you take them at the doses I give you to them, but they do quiet down the nerve endings in the gut wall so they're not creating so much pain. And over time, particularly some of the medicines up here like dizipamine and amitriptyline, they will actually heal those nerves, and you may not need the medicine after 6 months to control your pain. But these require a buy-in. These require that you're going to be on them for a while before you're going to see an effect. So you have to be patient with them. But those patients who are patient with these kind of medications will do well. They're not for diarrhea. They're not for constipation. These are for pain. So if your constipation or your diarrheal syndrome is associated with chronic abdominal pain, like irritable bowel syndrome with constipation predominance, then we may, not right out the gate, we may end up on these. A lot of times the medicines I just showed you, like the LINZESS and the TRULANCE and the MOTEGRITY and the ANTIBIOTICS will fix the pain, and you don't need to get into this drug class. But if the pain is vexing, we've gotten good control of the constipation, we just can't get rid of your pain, then we'll go into these neuromodulators. And they're safe for long-term use, and we use them quite a bit for chronic pain. All right. Again, nerve and pain control properties. We use much lower doses than depression. They do decrease the pain. They do decrease nausea. They decrease depression. They don't have much effect on constipation. And after 3 to 12 months, you should probably consider tapering them off and seeing if you're doing okay without them. One quick comment about antibiotics, particularly there's a condition called small intestinal bacterial overgrowth. The theory here that bacteria leave your colon, get up into your small bowel where they don't belong. There's a lot of data that this kind of bacterial overgrowth in your small intestine is associated with diarrhea and bloating. There is some data, not as much, that might be associated with constipation. There's a guy, Mark Pimentel, out at UCLA, who thinks this is a big cause of constipation. I'm not convinced of it quite yet, but sometimes we will look into whether if you have a lot of pain and particularly bloating and constipation, we might look into a hydrogen breath test to see if there are bacteria in your small bowel, or we might just treat you for it. Give you a rifaximin. It's an antibiotic. It's a nice antibiotic because it doesn't get into your bloodstream. It just works in the bowel, and it gets rid of the bacteria in the small intestine. Dose is pretty reasonable, 500 milligrams 3 times a day, 14 days, that's it. And it can the results in reduction in bloating and then sometimes constipation and occasionally diarrhea can last for months, maybe 6, 7, 8 months, and then you might have to repeat it. But it's pretty nice. I tend to use rifaximin and treat SIBO when people have a lot of constipation and bloating in particular. And if I've treated the constipation with the medicines I mentioned before, and I still can't get a hold of the bloating, that's still a big issue, we'll probably head off in this direction and see if this helps you. But like I said before, you would probably have to rinse and repeat, meaning you're probably going to have the symptoms come back in 3, 4, 5, 6 months, maybe up to 8 months, and then have to do this treatment again. But that's not too bad if twice a year we do that to help you get rid of your bloating. Diets, gluten-free diets are just not effective. They don't work for constipation. They don't work for diarrhea unless you have celiac disease, and that's only 2% of people who have these kind of complaints. People who follow gluten-free diet who don't need to have higher blood levels of arsenic and lead because the substitute for gluten is a rice protein. And rice, if you didn't know, particularly white rice, accumulates arsenic and lead as it grows in the ground. So you will get that increase if you follow a long-time gluten-free diet. Neither of those are healthy for you. So again, gluten-free diets are great if you have celiac disease. If the doctor thinks you have non-celiac wheat sensitivity, they're fine. But just going on a gluten-free diet in situations where it's not proven to be helpful does have some downsides. Gluten-free diets are associated with greater weight gain and a higher risk of diabetes. So there's downsides to those, and I can't give you an upside. I don't know any data that show that a gluten-free diet has been effective in constipation or constipation predominant irritable bowel syndrome. Now here's the one that might be. You might have heard about a FODMAP diet. That stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These are sugars in your diet that create a lot of gas and may lead to diarrhea. I don't use this diet very often in patients, a low FODMAP diet very often in patients with constipation, unless bloating is a big issue. I do use it fairly frequently in chronic diarrhea. So it's basically, we were talking about the Xifaxan a minute ago, that antibiotic. I'll start getting into the weeds of using a FODMAP diet when there's a lot of bloating involved. A FODMAP diet is difficult to do. So I really try to convince all my patients not to try to do this on their own, but come see our dietitian. There's a specific protocol for going through and adjusting a FODMAP diet that works for you. So if we're really having trouble with the bloating, we're having a lot of trouble with diarrhea, and we want to try this, we'll get you into our dietitians who will work with you on this diet. It's pretty, once you figure out which FODMAP diet works for you, it's fairly easy to follow. It's just figuring out which FODMAPs work for you and which ones don't that's difficult, and it's the reason you need a dietitian to help you. This is a general guideline we hand to patients about, the foods that contain that are low in FODMAPs and high in FODMAPs. But if you're really interested in FODMAP diet, if you have a smart phone or a cell phone that you can go to the App Store for Google or Apple And you can pull down the University of Monash FODMAP diet. Just type in FODMAP, and it's the one that has the icon that looks like a squiggly gut here. This is put together by the guy who actually invented the FODMAP diet, Peter Gibson at the University of Monash in Australia, and it's really good. So if you want to learn all about FODMAP dieting and you want a little guide to what has, fermentable carbohydrates and causes gas and bloating, this is a nice little app, and it's probably the most accurate and science-based one out there. So in addition to your dietitian, that can be helpful. So FODMAP diets improve bloating, abdominal pain, and diarrhea, but they haven't been documented to be that much better than conventional dietary advice. There may be some effects if you try to do a low FODMAP diet. So the best thing to do is a modified FODMAP diet. That is, leave in fermentable carbohydrates that are healthy for you and get rid of the ones that are not healthy for you. And that's easy to do with a dietitian. So I want to get into acid reflux. Let me see my timing here. Good. I got another 20 minutes and we'll finish up here with acid reflux. So acid reflux is simply the movement of gastric contents from the stomach back into the esophagus where they don't belong. You have a valve here called the esophageal sphincter that is supposed to tighten and protect your esophagus from acid and bile salts and other stuff in your stomach. That usually works for most people. But in people who have acid reflux, what happens is it's not that this valve just disappears and it doesn't work at all. It's that it relaxes when it should not. This valve should be tight all the time when there's stuff going on in the stomach. And unless you swallow, it should not relax. When you swallow, it should relax to let food in through and into the stomach. But as the stomach's grinding away with your food and mixing acid in there and some bile salts are coming back up from the small bowel, you want this thing shut. And for reasons we don't know, that's kind of the Nobel Prize research. We don't know why this valve stops working correctly. But in people with acid reflux, it relaxes temporarily when it should not. And when it relaxes and your stomach contracts, as it does 3 times every minute, acid and bile salts and activated enzymes percolate up into your esophagus, causing you heartburn, discomfort, regurgitation, burning, esophagitis, or inflammation and erosions in that area. And it's pretty uncomfortable. It can actually lead to stricturing and trouble swallowing over time. So I'll spend some time on treatments and then I'm gonna get into the long-term PPI issue a little bit. So lifestyle modifications. In the green are things that actually work. Do not eat before you go to bed. That is about the single most important thing you can do on your own with regard to acid reflux. Don't eat before you go to bed. Because if you eat before you go to bed, you're gonna fill up your stomach with acid and bile salts and food, and then you're gonna lie down. And now your poor valve, which is trying to keep your esophagus protected, doesn't have gravity helping anymore. And it's very easy for materials to percolate up into your esophagus at night. And the exposure at night is longer too, right? So during the day when you have an acid reflux event, you're sitting up or you're standing up, and that stuff gets cleared back down into the stomach fairly rapidly. But at nighttime, you're lying down and the esophagus has trouble getting that stuff out of there. So 2 to 3 hours before you go to bed, call it quits. Water's fine, no food, nothing. Sleep on your left side. Anybody who's got reflux has probably already figured that out, but if you sleep on your left side, you protect your esophagus. If you sleep on your right side, it's easy for stuff from your stomach to get into your esophagus. Now, on your back and your stomach probably doesn't help, probably doesn't hurt, but if you want to help yourself in your reflux, or particularly at night, sleep on your left side. Almost every patient I see with chronic reflux has already figured this out on their own. They don't know why, but they know if they sleep on their left side, they get a better night's sleep out of the deal. So that's a good one. Lose weight. This is most important in women. Women who have a decrease in their body mass index will see their reflux improve. Men, we're not as lucky. Unfortunately, it doesn't work as well for us. But again, losing weight will help everybody. It helps women more than men. Sometimes they recommend wearing looser fitting clothing. I mean, unless you're really cinching your belt up like insanely tight or wearing a corset or something crazy, this isn't going to help you much. Again, if you put on your clothes, you tighten your belt, you start getting reflux, well, then loosen the thing. But otherwise, I can't say I've seen that help much. This is an old adage, no peppermint, chocolate, caffeine. Not really. You have to really work hard. You have to eat a lot of peppermint, a lot of chocolate, a lot of caffeine to get acid reflux just from this alone. If you find these things bug you, then I'm all in favor. Like Mark Twain said, eat what you want, let the food fight it out inside. If you eat peppermint and you tolerate it well, nobody's gotten acid reflux from just eating peppermint. Nobody's gotten esophagitis from just eating chocolate or orange juice or caffeine. But if those things bug you, then by all means avoid them or eat them in small quantities. But particularly if you're taking medication for acid reflux, you can eat all this you want. You're not going to get into trouble. You can really do what you want there. So on to medications. So one of the key things to understand about reflux disease is that as a medical doctor, not a surgeon, I am really good at stopping acid reflux, and I am terrible and ineffective at stopping reflux. So I can keep you from putting acid in your esophagus. I cannot keep you from putting stomach contents into your esophagus. All the medications I use to treat acid reflux reduce acid, so that what comes up into your esophagus is benign. It's like water. It's totally harmless. But if you are uncomfortable because things are coming up, even if they're not acidic, then my medicines aren't going to help you. Now, getting rid of the acid works in 90% of people with acid reflux, so it works well. It doesn't really address the problem, right? I don't have a drug that tightens that valve for you. As a matter of fact, if you talk to surgeons, they'll tell you they are the only people who cure reflux disease, and they're kind of right about that. They go in there and they create a barrier. They take the bottom of top of your stomach and they wrap it over the bottom of your esophagus like the cuff on a pair of pants to create a new barrier for you. So they actually do fix the anti-reflux barrier. I don't have a drug that can do that successfully. So I do an end around. I get rid of acid and figure, well, she'll keep refluxing, but at least it's like water. It's not going to hurt anything. And that works for most everybody. But what it means is that the minute you stop taking the medicines I give you, your acid will come back and your acid reflux symptoms will come back. So for the most part, this is lifelong treatment if you really have acid reflux. Just to give you an example, I have acid reflux and I have been on Prilosec or one of these drugs since 1989 when I was put into the clinical trial when omeprazole came into the United States. So far I'm fine. I'm not demented. My bones are great. I feel good. But I will tell you that if tonight or tomorrow morning, I didn't take my PPI medication, I would have heartburn. It's instantaneous. Nothing has gone wrong with my acid pumps in my stomach. They're waiting for me. The minute I stop, putting the leash on them, they'll let loose and create acid and I'll have reflux. So I've been a bit of a guinea pig. I've been on the drug for 32 years or so. No harm so far. I know that if I stop taking them, I'm miserable, so I've been taking it. So I'm very attentive to these long-term side effects, obviously, right? I'm the canary in the mine for you guys. I've been on these drugs forever. So I pay a lot of attention to this issue. And I'll go into it in a minute here. So antacids like Gaviscon are only good for about 30 to 60 minutes of symptom control. They won't heal anything. When I have breakthrough symptoms, I'll take a slug of, Gaviscon and it'll put out the fire right away, but it's not going to do anything after 60 minutes. It's going to be gone. Histamine receptor blockers are what I used to take before omeprazole or Prilosec came out. These work pretty well, but, except Zantac got withdrawn from the market. These are all over the counter. They reduce acid by 65%. The problem is over time, they conk out. They lose efficacy. So you can take them for 2 months and you might do fine, but by the time the third month comes along, they're not going to work so well anymore. And that is the single biggest reason these drugs have never been great for people with significant acid reflux disease. If you want to take something here and there, you're going out to eat, you're going to be an acid reflux event afterwards, you want to take a little quick shot of Tagamet or something, that's fine, or Pepsid's great. They work really well if you have nighttime symptoms. A little dose at bedtime is helpful. But their main issue is they're not quite as effective as a proton pump inhibitor class drug, and they will conk out over time. Proton pump inhibitors. So this is what came out in '89. It really changed the landscape of treating reflux disease from something we were poor at to something we were great at. These are both prescription and over the counter, which shows you how safe they are. They're over the counter nowadays. They're extraordinarily effective. They get rid of 90 to 95% of your acid. And let me tell you, the kind of food we eat these days, you do not need a lot of acid to digest it. So reducing acid doesn't cause malabsorption of any kind of food or substance. You'll do fine. The little 5% or 10% you still make is plenty. Your stomach makes a ton of acid every day, and you don't need it all anymore because you're not eating a lot of raw meats and things, and we're doing fine with the kind of food we eat and the acid we produce. They do directly block the acid pump, so they do not lose efficacy over time. Mine, I'm taking them for 30 years, no trouble. They still work. They'll work tomorrow. They worked 30 years ago. There's lots to choose from: Prilosec, Nexium, Protonic, Zegrid, Acifex, Prevacid, Dexilant. I can't tell you that any one works better than any of the others. Some patients find one works better for them. I never argue with that. The data doesn't show a whole lot of difference, but who knows? Maybe some patients metabolize the drug a little differently and find efficacy. Prilosec is the first one, and it's a little bit weaker than these other guys, just from the standpoint of its total potency, but it still works in the vast majority of people. To be sure of hitting a target, shoot first and call whatever you hit the target. That's sort of been the issue with the side effects of these drugs. People say, oh, let's look at bone disease. Let's look at dementia. Let's look at cancers. And so they start with the target and then they try to backwork it and make the drugs the cause of it. And that kind of associative data can be hard to interpret and is a little bit risky. So let me go through all of these things with you, the benefits and the risks, and then you'll have a decent idea whether you want to take these meds long-term or not. When you assess drug side effects, we use two types of studies. We use what are called association studies. And these are the simplest, easy to do, and the weakest data. This is where we look back at everybody taking the drug to see if they developed a problem more than those who are not taking the drug. These are easy to do. These are quick studies, but they are the weakest information because of confounding factors. When we go back and look at everybody who had a bone fracture who was taking Prilosec, let's say, we don't know if there was another reason they were taking the Prilosec or other issues were causing their bone fracture. Those are called confounding factors, and they cannot be sorted out in these association studies. So these are weak data that you have to be careful with. These are the strong data sets. This is cause and effect analysis. This is where we look forward to see if those we give a drug develop a problem. Not backwards, we're looking forward. These studies are hard to do. They take a long time, but these are the strongest studies because they consider these confounding factors. They look to see if there's another issue causing the bone problems, not the drug we gave the patient. I will give you an example with regard to the bone density stuff, and the data there suggested that, oh, people who took Prilosec or other drugs like that were getting osteoporosis. That was the association study. There have been 7 now cause and effect analysis that did not show any risk of bone density loss with Prilosec. What they did find was that when people get osteoporosis, they get drugs that cause heartburn. So what do? They go to the grocery store and they buy some Prilosec. So if you look at these people with osteoporosis, you'll say, oh, look at all the Prilosec they're taking, not realizing that the reason they're taking the Prilosec is because we're giving them drugs that cause heartburn. So of course they take the Prilosec. So in all of the studies done in a cause-effect analysis methodology, no one has yet found osteoporosis as a side effect of proton pump inhibitors. So the GI societies have all backed off on that. So associations in studies do not equal causality. So you have to be careful about data sets. So I'm going to go through the associations only where there is no clear cause and effect analysis present at the time. One is stomach cancer. Nope, can't find, there's no risk of stomach cancer in taking these drugs. 2, iron deficiency. We have not found that taking these drugs alone can cause iron deficiency. 3, B12 deficiency. We have not found any data that they cause B12 deficiency. That said, if you have some other reason for B12 deficiency and you take an acid suppressive medication of any sort, it might make your innate B12 deficiency worse. But by themselves, Prilosec, Nexium, pantoprazole will not cause you to be B12 deficient. Osteoporosis or bone loss. There are now 7 analyses that have not shown any correlation between osteoporosis and proton pump inhibitor use. So no, it does not cause osteoporosis. It does not cause colon cancer. They do not increase your risk of bowel infections. They do not worsen congestive heart failure. They do not interfere with blood thinners like Plavix. Okay, so, and I forgot one, I didn't see that. They do not cause cognitive decline. So I should have added one more in there. There was some data that suggested patients with Alzheimer's use these drugs more often. That also got sorted out as no cause and effect. So you may have heard about these things. I cannot give you one shred of data that any of these are true. This is all considered currently by the GI societies and mythology. Here's where there's some viable concerns. There have been reports of a low blood magnesium level in people taking these drugs for longer than 3 years. So once a year, the FDA advised that we check your magnesium level. If it's low, we give you extra magnesium to take. It appears that some people have a genetic change in their kidneys that make them leak a little magnesium when they're on a drug like Nexium or something. So we just check that. Now, this I will say is true. About 4 to 5 months ago, a publication came out showing that if you're on double dose PPI'S, meaning you take twice the normal, dose you're taking, let's say Nexium in the morning, afternoon, there is increased risk of COVID-19 infection. So the advice there was, if you don't need your PPI, hold off, maybe take some Tagamet or Pepsid instead, or at least go back down to once daily dosing until you get your vaccine, and then you can, get back on what you need. But there is increased risk of COVID, so I do want to make that clear. That is a potential risk. There is a risk of rebound acid elevation. I notice this if I forget to take it or I run out and I don't have any, I'll get a little more heartburn than usual right when you stop it, because the acid comes back at a higher level for a couple of days. So if you keep stopping and starting and stopping and starting the drug, you'll notice this rebound of that. Microscopic colitis is a very mild type of colitis that you actually can't see with an endoscope. You can only see on biopsies. Seems to only occur with Prevacid. So if a patient gets diarrhea on Prevacid, we just shift them to another one. It resolves when you stop the Prevacid. If you're taking an antibiotic with a proton pump inhibitor like Nexium or Prilosec, you probably want to hold it, because there is a little bit of an increased risk of this infection in the colon when you're on antibiotics and a proton pump inhibitor. However, just taking the proton pump inhibitor alone isn't going to cause you to have this infection. It's got to be coupled with antibiotics. And probably the most serious thing is this weird allergic reaction in the kidneys called interstitial nephritis. Don't know where it comes from. A lot of drugs cause interstitial nephritis. It's kind of an allergic reaction in the kidneys to the drug. Simply, when we're checking your magnesium once a year, we check your kidney function. If we see the kidney function declining, we will end up stopping the drug. And that's the one where I can't put you back on it. That one will come back. But this is rare, about 1 in 2,000 people. So what should you do? I think PPIs are very important for those with reflux, because they protect you from things like esophageal cancer, esophageal injury, esophageal strictures, throat and lung injury, and they just make you happier because you're not dealing with heartburn all the time. But what can you do to keep yourself safe with them? One, check your blood magnesium level yearly, and all my primary care docs do that, and I do that. We check your kidney function once a year. Almost everybody gets this done anyway. We use the lowest dose. If you can get by with once a day, great, do that. And if you're taking some antibiotics, let's say you got a skin infection or you have a pneumonia and they want you to be on antibiotics, why don't you hold your proton pump inhibitor while you're on the antibiotics? If you really have bad heartburn, switch over to Tagamet or Pepsid for a few days, and then you can go back onto your Nexium or your Prilosec. And then if you're on Prevacid and you're getting diarrhea, just switch to another one. Switch to Nexium or Dexilant or Prilosec, and you should be okay with that. So this is it. This is what I counsel my patients on. It's a yearly blood magnesium level, yearly check of the kidney function, use the lowest effective dose, pop them off the drug if they're going on an antibiotic for a couple of weeks. Don't use Prevacid. I don't use a lot of Prevacid anymore anyway. And that's about it. I think the other things have been proven to be not significant issues. We've seen no problems in myself personally or any of my patients. So this is the device I follow with my family and myself as well. So that's it. I think I'm close to time there. Yeah, perfect. 2:02.
Perfect. Thank you, Dr. Brown. That was excellent.
Yeah, no problem. Let me stop sharing here.
Okay, perfect. And we have a number of questions. This is actually the most questions we've ever gotten at a lecture. And I think that shows me how invested and interested people are. So we'll go ahead and get started. First question, how often do you see bowel-influenced constipation via cervical myelopathy stenosis?
Okay, so constipation. So anybody who's had anything done in the pelvis, that can be surgery, radiation, etc. The pelvis is a small area, and so distensions so patients who have uterine fibroids can get into trouble. Anybody who's had radiation in that area can get scarring of the rectum that can lead to constipation. If you've had surgery in the pelvic floor, that can lead to adhesions and scarring in the area that can lead to outlet type constipation. So most people have had any kind of surgery or treatment or resections or radiation in the pelvic floor. Those are patients we go pretty quickly to evaluating them for an outlet constipation issue, not just a motility problem with the colon, but something structurally blocking the colon up. And in that setting, those tests I mentioned, defecography and anorectal manometry, are done to define what the problem is and then come up with an appropriate solution. The problem with people who have outlet constipation is if you keep giving drugs to increase colonic motility, you're pushing up against a dam. The analogy I make is like trying to empty the bathtub without pulling the drain plug. I mean, you keep filling up the bathtub with water, but it ain't going anywhere unless you pull the drain plug. So a lot of patients get frustrated when they have outlet constipation related to pelvic surgery or pelvic radiation. because the physician didn't recognize that problem and didn't assess them for obstructed defecation. Some obstructed defecation requires surgery. Some of it requires physical therapy. So I didn't mention that, but we have a pelvic floor physical therapy group here at Rush in the Rush Oak Park who do pelvic floor physical therapy for people with obstructed defecation. And in men and women who have obstructed defecation with a definable pelvic floor abnormality that does not require surgery, but is a muscle problem, 87% will get better with a course of pelvic floor physical therapy. So it works really well.
Wow, thank you. The next question, can drinking sufficient water move waste through the colon?
Yeah, it can if you give it help. So as I mentioned, you're going to have really clear urine if you drink a lot of water. It'll help move waste through the kidneys, but it won't help it get it through the colon unless you pull the water there. And the only way to pull water into the colon is with fiber supplements or osmotic laxatives. That's going to be Miralax, milk of magnesia, any of the magnesium-based laxatives. Lactulose is fine. I'm not, like I said, a huge fan of that because it creates a lot of bloating. But Miralax, which is over the counter, and milk of magnesia are great for pulling water into the colon. So if you drink a lot of water with those, you take those once or twice a day, yes, you'll get more water in the colon. You'll have a softer, easier to pass bowel movement.
Okay. Is difficulty passing gas with bloating and pain likely a symptom of partial fecal obstruction?
Yes. So, right. So if you have a fecal impaction, then the symptoms you'll have will be incomplete evacuation, bloating, usually lower quadrant abdominal pain. So when we see people like this in clinic, we usually do that flat plate x-ray of the abdomen I showed a picture of, and we often find a lot of fecal retention. What we typically do then is we use a colonoscopy purge or prep to clear the colon completely, eliminate the fecal impaction, and then get somebody started on a bowel regimen that keeps the colon moving along so that they don't accumulate fecal material in the left colon. Your left colon is a storage tank. It is the area of the colon that is involved in holding fecal material until it's time to have a bowel movement. Sometimes when when the stool overstays its welcome in there and it builds up, you get a fecal impaction, and that can be uncomfortable due to the stretch on the colon wall created by the residual fecal material. And as I mentioned before, is the more fecal material in your colon, right, the more fermentation taking place, so the more gas you produce. And if the gas cannot get out below, it's just going to head up north back into the small bowel. You'll feel bloated and distended, and you'll actually physically notice bloating too.
What do you think of the product Calm, a powdered magnesium? It is the only thing that has helped me attain normal daily bowel movements.
Yeah, I don't know quite what's in it. I know it's a magnesium-based compound, so magnesium is wonderful. I use a lot of magnesium. You can't get toxic with magnesium. Any magnesium that you absorb, your kidneys will urinate out if you don't need it. Magnesium helps avoid leg cramps at night, so you get that little benefit. And it's a wonderful laxative. It helps pull water into the colon. It stimulates colonic motility. It's totally safe. It doesn't interfere with anything. It doesn't interfere with any medications. Only side effect is, diarrhea. So yeah, so any product you find on the shelf that contains magnesium is going to work as a laxative, an osmotic laxative. It's going to be safe and will make the water you drink more effective.
Great, and we have 5 more questions online.
No problem.
The next one says, Bravo test shows acid, much more than normal. Don't have actual numbers available. How do you recommend the acid reflux be monitored? Is every 5-year endoscopy, colonoscopy combo frequent enough?
Right. So with reflux disease, there's 2 reasons you get repeat endoscopy. One is because somebody went down there and found this precancerous condition called Barrett's esophagus, and that should be followed up every 5 years. If on your first endoscopy in your life with reflux disease, they don't find Barrett's, you're never going to get it. It's a once in a lifetime thing. If they don't find it, you don't have to worry about Barrett's ever again. It's just not an issue for you. If they find it, it's not a big deal. It just means we need to check you every 5 years, and you got to be good about controlling your reflux. Barrett's does indicate a high exposure to acid in the low end of the esophagus, and Barrett's is where the esophagus changes itself into the lining of the small intestine. It figures, well, if you're going to throw acid up in here, I might as well change into the lining of the small intestine, which is pretty tough against acid. The only problem with it is that when you grow the wrong tissue, albeit in the right place, you have this increase in cancer risk. If you don't have Barrett's, you don't need repeat screening endoscopy like you do colonoscopy. If the other reason we do endoscopy is if people develop warning signs. So say they're bouncing along with their medication, they're doing fine, and now all of a sudden it doesn't work anymore, or they can't swallow, food's getting stuck, or the pain's a lot more severe or different in character, then we'll look again. But there is no need to monitor somebody routinely with endoscopy who's doing well on their acid suppression medication. Now, if somebody's had a Bravo test and it shows acid exposure considered abnormal or consistent with reflux disease, and they are not responding to high doses of Nexium or Prilosec, then that would be a candidate for surgery. And that would be somebody who could consider a laparoscopic repair of that valve to prevent reflux. If somebody has a Bravo study that does not show a lot of acid and they're not responding to acid suppressive therapy, then we're barking up the wrong tree. It's not acid that's causing the trouble. It may be neural sensitivity. And that's where they come back to me. And that's where we start talking about using those neuromodulators that I mentioned earlier for controlling pain. Because their surgery is not going to help at all. It's not an issue of acid reflux if the Bravo is negative, and that's the reason they weren't better with Nexium. The reason is because the nerves are too sensitive, and we have to work on that.
Thank you, Dr. Brown. Next one says, I may have missed this, but what can you do that's natural besides smooth move for constipation?
I would say the most natural thing would be magnesium. I mean, magnesium is part of your diet. It's a normal electrolyte that your body uses effectively to improve neural communications. It's important in muscle strength. Fiber is another natural way. So if you want to get fiber in a natural, so the fiber supplements you buy over the counter, they are natural. I mean, they're made out of plant substrate there. So they take plants like psyllium as a plant fiber, and they just grind it up and turn it into a powder to make it easy to take. But if you want to do it really naturally, then you can go to the store and buy all the fiber you want in the form of berries, and I mean, other fruits and vegetables have fiber too. The brand-based cereals, so the cereals on the top shelf that nobody likes, those have a lot of fiber. Get those work well too. So diet's the most natural way to treat constipation by increasing fiber intake. The second most natural way to do it is probably through magnesium-based osmotic laxatives. But you have to be careful about the term natural, right? Because senna and cascara are from the roots of plants. They're natural, but they can damage the colon neurologically. So you can hurt yourself with natural approaches. So I would rather a patient be on a pharmacologic like Amitiza than be taking senna or cascara every day. There's no damage to long-term Amitiza use. There is damage to senna and cascara use. But yeah, the natural way is either fiber supplements that you buy over the counter, or fiber in the form of increasing fibrous food intake, or magnesium-based osmotic laxatives.
If Tums works effectively for years, is it fine to keep using them? And what about digestive enzymes before eating known problem foods for acid reflux?
Okay, so Tums. So Tums is a quick-acting antacid. It lasts about 30 minutes. As long as you're just having these brief episodes, Tums is fine. I mean, if you just have a little brief burst of acid reflux here and you want to settle the acid for 30 minutes, Tums is great. The key thing about Tums is don't take a ton of it. Don't take 20 Tums a day. So, 4 or 5 a day is okay. But if you're getting into, you can get some serious electrolyte abnormalities if you're taking, 20 or 30 Tums a day. I've had people do that and they can get some kidney trouble with it. So yeah, you just don't want to overdo it. And if you find that you need to take 10 Tums a day, then you're probably better off on, some Zantac or Prilosec or something. Not Zantac, it's pulled from the market, but something else than just taking a ton of Tums. The other part of that question, I think, was, foods.
Yeah, and what about digestive enzymes before eating known problem foods for acid reflux?
Okay. So as I mentioned, the acid reflux, it's interesting. We always talk about caffeine and chocolate and peppermint. You can really eat those all you want as long as they're not causing trouble. They're not going to give you an orange juice. The foods that actually cause the most reflux are going to be high-fat foods, right? Because they slow stomach emptying. So there's going to be more material in the stomach to reflux. So high-fat diets are probably more problematic for people with symptomatic reflux. From the standpoint of pancreatic enzymes, unless your pancreas is 90% destroyed, you don't need them. Your pancreas produces millions and tens of millions of units of enzymes every day, compared to the amount of enzymes in a tablet you get over the counter, which is, I'll give you an example. Your pancreas, every time you eat, produces about 2 million units of lipase. When you go to the store and you buy a pancreatic enzyme tablet, it has about 8 to 10,000 units of lipase. So basically taking a pancreatic enzyme tablet compared to what your pancreas produces every day is, like dumping a bucket of water in Lake Michigan. It's not going to make any difference. Now, if your pancreas is destroyed, if for, chronic alcohol ingestion, you have chronic pancreatitis, the pancreas is no longer working, then yes, enzymes can be helpful. But that's the only situation which they're helpful.
All right, and the last couple questions. Why does PPI use increased risk for a COVID infection?
Yeah, great question. So unfortunately, COVID infection can be, we think there's some transmission through the GI tract, that it's mostly inhaled, but there may be a way in which it can be ingested and get through. This is the reason that, we were talking about cleaning things and not touching your mouth or anything like this. So it gets in through your eyes, gets in through your nose, seems to be able to get in through the GI tract. The other possibility is that, during the day, you may have some, there's always some removal of material in the stomach back up into the throat and into the esophagus. It may be that very tiny amounts of aerosolized gastric contents can get into the lungs and then cause an infection. Acid in your stomach is a pretty good sterilizer. If COVID gets down in a pile of acid, it's not going to last long. So the theory is, particularly in the higher doses, is that COVID that might be ingested in some way could end up in the stomach and either get absorbed through the GI tract, which seems unlikely. More likely, when you burp and you aerosolize gastric contents, it may get back into your mouth and get inhaled. So it's not a big risk. I don't want to make it sound like it's twice what the baseline risk, but the baseline risk is 3%. So you're going from, a baseline risk of 3% to a baseline risk of 6%. So it's not huge. But yeah, you try to use the smallest dose you can during the pandemic. When you get vaccinated, you can go back to whatever dose works best for you.
Very interesting. Last question on YouTube. Does drinking with a straw cause more gas?
Oh, that's a good question. Yeah, so when you drink with a straw, yes, you do take in, to drink with a straw, you have to inhale in order to swallow. Whereas when you drink just regular wise, there's no inhalation associated with that. So yes, you will take more air in if you drink with a straw, which means you will burp more and you will pass more flatus. So yep, that's a good question. Yeah, it does, because you have to suck on the straw, so you got to take air in. So.
Wow, thank you. And then for the last few minutes, I just want to open up for anyone who joined in over the phone. If you wanted to ask a question, you can unmute yourself now.
Hello, doctor.
Hi.
How are you? I was just wondering, another excellent program with Rush Generations, always great.
Great.
And the question is, they said I shouldn't have surgery for diverticulitis. But is there any way to get rid of them or without surgery? And also, is smart water good for electrolytes?
Yeah,
I'm not crazy about the.
Yeah, so it has a little extra electrolytes. It's not like Pedialyte. If you really want to replenish yourself, let's say you had a bad diarrheal episode, you wanted to replenish, you're better with Pedialyte. I don't know if you saw a recent ad on TV where the dad looks kind of wiped out. I don't know if he's been running or he's got sick and he's drinking his kid's Pedialyte and the daughter's complaining at him. Yeah, so Gatorade and Smart Water and what's the other one? Powerade do have a modest amount of sodium, potassium in them, so they'll help you. If you've been exercising aggressively or you feel dehydrated, they're fine. If you really want to do electrolyte replacement, then Pedialyte is the way to go. That contains a lot more in the way of electrolytes. Your other question, diverticulosis is interesting. Diverticular disease is a manifestation of an aging colon, and you can figure out whether you've got it or not by your decades in life. So if you're in your 70s, you have a 70% chance of having it. If you're 80s, 80% chance. It is not reversible. There are little pockets related to the deposition of a compound in the wall of the sigmoid colon called elastin. I can't reverse it. Most people with diverticulitis don't need surgery anymore. We're really backing off on that. We don't view it as an infection, but more as an immune event. We're even starting to treat it not with antibiotics these days, but with medicines that reduce the aggressiveness of the immune system, like an inflammatory bowel disease. So I'd say in the last 5 years, our concepts of diverticular disease, that's another Rush Generations lecture, that's changed a lot. But no, you can't make it go backwards. The only way to get rid of them is have a surgeon cut them out. I would not advise that unless you've had a really bad case of diverticulitis with a lot of abscess formation and such. Most of the diverticular disease is asymptomatic. When it is symptomatic, it usually just requires a little of a medicine like mesalamine or some probiotics. Probiotics are good for it. I would add that. There's some decent data there.
Great. Thank you so much, Dr. Brown, for this lecture. It was excellent.
Yeah.
I'm so happy to see the comments too. It sounds like it went really well for our participants too. So
yeah, I can come back and talk about diverticulosis someday. That's another popular topic.
Yeah. Thank you.
Okay. Talk to you later.
All right.
Bye, everybody.
Bye. And right now, for everyone who's on the line, I'm going to just share some of our upcoming programs. And so here we go. All righty. So first we have our COVID support group. So this takes place the third Wednesday of every month over the phone from 3 to 4 p.m. So if you're interested in joining the COVID support group, again, that's the third Wednesday of every month from 3 to 4 p.m. And it's led by one of the social workers on the Rush Generations team. And if you'd like to get more information about that, you can call our Rush Generations toll-free number, which is 800-757-0202. Next, we have our Take Charge of Your Diabetes workshop coming soon. That is from February 8th till March 22nd on Mondays from 10 a.m. to 12 p.m. So again, this is the Take Charge of Your Diabetes workshop. This is a free workshop that's geared towards learning how to manage diabetes and setting goals and how to accomplish them and learning more about how to manage your health. And so if you're interested in registering for this, again, the number is 800-757-0202. Next, we have our Rush Caregiver Initiative. So this is great for those of you who may be a caregiver yourself, or if you have a caregiver. This will offer a customized approach to supporting you. It starts off with an assessment to see what the needs are, and then goes from there. So if you're interested in getting an assessment with the Caregiver Initiative, you can call the Caregiver Initiative at 312-563-0350. Lastly, we have our Shaman Senior Voices program. So for, especially now while we're staying at home, we have the website, which is aging.rush.edu/SCHAALMAN. And on the website, you can see videos from older adults and caregivers in the community sharing their perspectives on aging, as well as other videos that were done professionally too, with leaders in the community sharing their perspectives on aging. There's also an opportunity for you to record your own video and tell us what matters most to you as you age. So if you're interested in getting involved, you can also call our Rush Generations number at 800-757-0202. And just a final reminder that we're here with you during this time of social distancing and staying at home. We have a number of programs just like this lecture, as well as workshops and support groups and volunteer opportunities. So if you're interested in getting connected to a program or hearing more, you can call our toll-free number again at 800-757-0202. Thank you all so much for attending, and we hope you have a great evening.